morning, students. A very good morning to all of you. Today I would like to cover a few aspects about poisoning in children. So coming to the definition of what is a toxin or a poison, it's a substance which when introduced into or absorbed by a living organism causes injury or death. So the study of the predictable dose-dependent effects that result from an overdose of the potentially harmful agent is what we call as toxicology. So just adding few more points to the poison that's harmful to the body, it can be either ingested, inhaled, injected or even absorbed through the skin. So we should be very clear, it does not include the adverse reactions of medications which have been prescribed. So that's an entirely different topic. It doesn't come under toxicology or poisoning. So poisoning can be an intentional poisoning where a person is taking a given substance out of intention of causing self-harm, or it can be deliberately done by a person to cause harm. So it can be suicidal or even an assault. Coming to unintentional poisoning, if the person is taking or giving a substance and did not mean to cause harm, then it can be called as unintentional poisoning. And sometimes when you are not able to distinguish whether it is intentional or unintentional, you will put it as an undetermined cause for poisoning. So coming to the pediatric age group per se, how is it different from poisoning in adults? So pediatric toxicology has two distinct parts. One is a young child between 1 to 5 years who innocently takes in a small amount of a substance. And usually it will be a single substance because it is a accidental consumption. This is the first group. The second group is our adolescents who purposefully ingest a large amount of substance either because of emotional or a psychiatric distress. So, why is poisoning in children different from adults? One is because of the developmental age. So, each age group is vulnerable to particular type of toxins, and some of the physical considerations, that is, age-related vital signs and certain parameters are different in a child compared to an adult. So, these two are important distinguishing points. Coming to the routes of administration, so it can be the maximum chunk is by ingestion, that is almost 79% of the poisoning cases in children is usually due to the ingestion. Other thing is dermal exposure, ophthalmic or inhalational. So this is just a famous saying by Paracelsus who says what is there that is not poison. All things are poison and nothing without poison. So what solely determines whether it is a poison or not is the dose of that substance. So I would like to, poisoning itself is a huge topic where there are many components which can cause poisoning. But here I would like to cover the major poisoning which we see in children. So I will cover the hydrocarbon, in particular the prototype, that is the kerosene poisoning, organophosphorus poisoning, datura poisoning, paracetamol overdose, iron overdose and corrosive poisoning in children. So coming to the kerosene poisoning. So it is more common in communities where kerosene is the major household fuel, and usually it is accidental consumption. So what constitutes a hydrocarbon? It is both organic as well as inorganic, and they have varying amounts of carbon and hydrogen. So of all the childhood exposures, the kerosene contributes to around 3.1% of the poisonings. And coming to the death, it almost constitutes almost 12 to 25% of all poisoning deaths in children less than 5 years of age. So, just briefly, you need to know what is the classification of hydrocarbons into aliphatic, aromatic, toxic hydrocarbons, and petroleum distillates. And one more classification is based on the toxic potential of it, like they are called non-toxic hydrocarbons, systemic toxic, and aspiration hazard. So, the group that we are mostly worried about is the one with the aspiration hazard, that is turpentine, gasoline, kerosene, ether, petrol, naphtha containing, the furniture polish, lighter fluids, and mineral spirits. These halogenated hydrocarbons are the ones which get very well absorbed from the GIT. So, they are known to cause the systemic toxicity like camphor. So, as I have already told, the routes of exposure can be either ingestion, inhalation, or even through skin contamination. So, most common what we see is hydrocarbon poisoning are due to aspiration. So, this aspiration can occur when the child is consuming, or he may just vomit out after consuming few drops, or during the gastric lavage. So coming to the pathophysiology of hydrocarbon poisoning, so the toxicity of hydrocarbon is directly related to the volatility and viscosity and the type of substance. So what we should understand is once the child consumes it, if the hydrocarbon is very viscous, the child tends to aspirate it. So aspiration is inversely related to viscosity. That is, lower the viscosity, higher the aspiration potential. So once the kerosene is aspirated into the lungs, it acts like a foreign body. So there is a foreign body reactions in the airway, and this kerosene is highly irritant. So on initial aspiration, there is irritation of the oral mucosa and the tracheobronchial tree. So this may be seen within minutes of the exposure. Cyanosis may occur due to displacement of the alveolar gas by the kerosene, and there can be bronchospasm which can further aggravate the ventilation perfusion mismatch which has already occurred because of the kerosene aspiration. So what happens once this kerosene reaches the pulmonary alveoli is it inactivates the surfactant which is aligning the alveoli. So because of the dysfunction of the surfactant, the lung surface tension of the alveoli reduces and there is areas of atelectasis which leads to destruction of the airway. So, as these areas of atelectasis progress, it can cause pneumonia-like picture, and it is because of the chemicals. So, it is called chemical pneumonitis. So, there will be areas of edema, hyperemia, leukocyte infiltration, and vascular thrombosis. It is almost like what happens in a bacterial pneumonia. But only thing here is the preceding event is the aspiration of the kerosene. So subsequently, these small patchy areas of pneumonitis join together to form a large patch of bronchopneumonia. So this can further progress on to cause diffuse hemorrhagic alveolitis, bronchial necrosis, microabscesses, and alveolar thickening. Sometimes kerosene can also cause partial obstruction, like in the foreign bodies. So it will lead to air trapping. So air can enter into the lungs during inspiration, but is not able to uh, exit out of the airway. So there will be areas of emphysematous changes, pneumothorax, and pneumomediastinum. So then we should know what is the fatal dose. So what they say is ingestion of even few 10 to 15 ml of kerosene may be fatal, but we have seen recovery even with larger consumption. So depends on whether the child actually aspirated whatever the child has ingested. So that is what determines the fatality of the aspiration. And fatal period is there for a few hours, almost 4 to 6 hours from consumption is the most vulnerable period. So coming to the clinical features, so as soon as a child consumes, ingests kerosene, because of the taste and smell, child may start choke on the kerosene. He may gag and he may cough. And during this process, he may aspirate some of the kerosene, following which child may develop some gasping type of breathing. So once the kerosene enters the lung, so as I already told, it displaces the alveolar oxygen. So this causes cyanosis and tachypnea, and it may progress within minutes to severe respiratory distress. So how do you recognize that? In the form of nasal flaring, child may develop grunting and severe chest retractions. So all these can take around 2 to 6 hours to develop in few children, and in few children it may be within couple of hours. So when you auscultate such children, you can hear decreased breath sounds with wheeze and crepitations. So this pulmonary symptoms will progress on the day one from the first 24 hours, and it gradually subsides by second to fifth day. If it's a very large aspiration, then child immediately develops a severe respiratory failure and hypoxia. So all this was of the respiratory symptoms. Sometimes child may develop other symptoms also like vomiting, nausea, abdominal pain, GI disturbances, tachycardia. Tachycardia could be because of hypoxia itself, and sometimes rhythm abnormalities again could be triggered by the hypoxia, and CNS effects. Child could be very hypoxic, irritable, or even sometimes comatose. Child may develop fever because of the chemical pneumonitis, and some of the children can present with hepatic injury even in kerosene poisoning. And it is more common with our halogenated hydrocarbons like CCl4, your carbon tetrachloride, which is known to cause hepatic injury. And very rarely we can see renal injury also, and it usually presents like acute tubular necrosis, hematuria, proteinuria, or even a glomerulonephritis like picture. So how do you investigate such a child? So approach to a child with poisoning is first take a detailed history to know what is the poison ingested, what is the quantity, when was it, and you will thoroughly examine the child to ascertain whether it is the same poison which has caused the clinical symptomatology. So then you would like to investigate. So among the routine investigations, one is CBC. So you may show leukocytosis because of the chemical pneumonitis, neutrophil infiltration. So even blood may pick up some amount of leukocytosis. Chest X-ray is the most important investigation because initially it may be normal, because as we spoke in the pathophysiology, the aspiration, the pneumonitis, all that takes few hours to develop. So even if the initial X-ray is normal, if there has been a significant kerosene ingestion with aspiration, you need to repeat a chest X-ray after 6 to 8 hours. So initially the X-ray which was normal can then show pictures of bilateral fine motile densities. So this is what we were speaking of, chemical pneumonitis like picture, and gradually it will coalesce to form large patch of bronchopneumonia. So that can be picked up on the X-ray. And as I was telling, they can also have air trapping because of the kerosene which acts like a foreign body mechanism. So they can have areas of hyperinflation, emphysematous changes, pneumatoceles, and in when it progresses on, they can even present with severe pneumothorax. And children always it's better to do a arterial blood gas to look for hypoxia. Okay. So this is the X-ray I was speaking about. Initially it may be normal, but gradually you can notice in the first picture there are some mild perihilar opacities, and after few hours if you see bilateral there is opacification. So this is the bilateral basal infiltration. So coming to the management of a case of poisoning, so in all the poisonings you should remember this. There should be one is a primary survey, second is a secondary survey. So in primary survey it is A, B, C, D and actually you can add one more E. So always remember primary surveying management is A, B, C, D and E. So A stands for airway. That is whether the airway is maintainable, whether the child is breathing well, whether he can maintain the breathing. So that is A, airway. So B is whether child is breathing on his own. What is his breathing pattern? So whether he has any gasping respiration or whether he has any deep sighing type of respiration. So assess the type of breathing. So that will be your B. Coming to C, it is the circulation. So you should see whether how is the child's pulses, whether the child is in any shock-like condition. So assessing the heart rate and peripheral pulses. So that will give us the idea of the circulation. By D stands for disability. So how do we assess disability? By disability, we don't mean like a child is not able to have some paralysis. In primary survey, D stands for disability. Indirectly, it tells about the higher mental function of the child. So that we usually assess by AVPU. That is, A stands for child is alert, V stands for child is responding to verbal commands, P stands for child is responding to painful stimuli, and U is totally unresponsive. So to assess the D or disability, we say AVPU. So alert responds to verbal stimulus, P is responds to painful stimulus, and U is unconscious. So I told you about another E in the primary survey. So E stands for exposure. So exposure can be like it can be a site of accident. So exposure will become a trauma there. So if it is a poisoning, so exposure stands for what is the poisoning that the child has gone through. So remember this primary survey A, B, C, D. So in all the poisonings, you have to do this primary survey. Then comes the secondary survey where we evaluate and see whether so what is the effect of the poisoning that the child is going through, and then we will do the detoxification phase. So in kerosene consumption, detoxification is cutaneous and GI decontamination. So if the child was wearing some clothes when he was accidental, say when they drink a kerosene, so some may be just spilled on the cloths that the child is wearing. So always remove all the clothing which the child was wearing during the time of consumption, and child needs to be thoroughly washed with soap and water because skin absorption is also known in cases of hydrocarbon poisoning. So we should remove all possible sources of kerosene contact from the child. So coming to GI decontamination, any poisoning, our first instinct is induce emesis or do a gastric lavage and remove the poison. But as we were telling, all these hydrocarbons, kerosenes, because of the viscosity, they have a very high risk of aspiration. So if you induce emesis or if you attempt a gastric lavage, then you are putting the child under risk of further aspiration. So this is one condition where induced emesis or gastric lavage is contraindicated. So you are not supposed to do that. But there is an exception to this rule, that is CHAMP hydrocarbons. If the child has consumed these group of hydrocarbons, then it's always better to do a gastric lavage because as I was earlier telling, some of the hydrocarbons do not have much of aspiration potential, but if they are absorbed from the GIT, then they cause a lot of systemic toxicity. So what are these CHAMP hydrocarbons? C stands for camphor containing hydrocarbons, H for halogenated, A for aromatic hydrocarbons, M for heavy metal containing hydrocarbons, and P stands for pesticide containing hydrocarbons. So if the child has consumed any of these hydrocarbons, then you can do the gastric lavage. Otherwise, it is contraindicated. So coming to the specific management, we have to closely monitor the respiratory symptoms and signs. As I was telling, the lung condition may worsen over the hours. Child may go in for a ARDS like picture. So close monitoring. For mild cases, just oxygen therapy will be sufficient to correct the hypoxemia. But if child develops severe respiratory distress or ARDS like pictures, then we have to consider a ventilatory support also. There is some benefit of using bronchodilators like salbutamol through nebulization. So as we were telling, there is some amount of bronchospasm also which is induced by kerosene aspiration. So that can be relieved by giving the salbutamol nebulization. In old time, we were using steroids for severe kerosene poisoning, but the present recommendation is steroids have no role and there is no need to start antibiotics prophylactically in these children because it is just a chemical pneumonitis. It will just take time and it will heal on its own. There is no need to start prophylactic antibiotics. So, no role of steroids and no role of prophylactic antibiotics. So it's always better to prevent than treat. So this is what we call as anticipatory guidance. That is, as far as possible, try to prevent the event. So how can we do that? Counsel the parents to keep harmful substances likely to cause poisoning away from the reach of children. And kerosene, if it is being used at home, should be properly stored in capped containers which child cannot easily open. And avoid keeping kerosene in like colorful containers like your Coca-Cola bottles or Pepsi bottles, which will attract the child. Child will think that it is a beverage and he might inadvertently consume the kerosene. So these things should be avoided to prevent the kerosene aspiration. So moving on to organophosphorus poisoning. So organophosphorus, there are mainly two sets of compounds, organophosphorus and organocarbamates. So these are the main class of pesticides which is being presently used, maybe for agricultural or even domestic purpose. So they account for almost 80% exposure to insecticides. And presently our agricultural industry is widely using all these pesticides and that's why it has caused more incidents of pesticide poisoning. So what is the basic pathophysiology of organophosphorus poisoning? So what happens is, so this is a normal synapse where this is a presynaptic neuron and a postsynaptic neuron. So presynaptic neuron have all this acetylcholine in them and your postsynaptic neurons will have receptors for this acetylcholine. So normally what happens is when an impulse has to travel, the presynaptic neuron releases your acetylcholine which comes and binds to the acetylcholine receptor and which transmits the signal. So this is the normal pathology, normal phenomena. But if it keeps continuing, so there has to be some regulation of this mechanism. So that regulator is your acetylcholinesterase enzyme. So when they have to stop the signal transmission, that is when the adequate transmission has already occurred. So at that time what happens is these acetylcholinesterase will come and deactivate or break down these acetylcholine so that the signal transmission is stopped. So this is what is a normal process. But what happens in organophosphorus poisoning? So these organophosphorus compounds, they come and bind to this acetylcholinesterase. So because of that, this synaptic transmission keeps continuing. So acetylcholine keeps getting released, it keeps getting bound to the receptors and it keeps transmitting the signal. So there is an excessive amount of signal transmission which occurs because of these organophosphorus compounds. So till a certain point, this acetylcholine will keep releasing and you will get the typical symptoms of organophosphorus poisoning. But after some time, the receptors also will be saturated and the amount of acetylcholine that can be released also locks down. So there will be a burning out phenomena. So this is what is I was telling. So the primary mechanism is it inhibits the acetylcholinesterase by irreversibly binding to it. So what happens because of this inhibition? There is subsequent accumulation of acetylcholine at the neural synapses, which leads to overstimulation, followed by eventual exhaustion and disruption of the postsynaptic neural transmission. It can occur both at the central and the peripheral nervous system. So based on which part it is affecting, the clinical manifestations can be muscarinic, nicotinic and central receptor stimulation. So coming to the clinical features, so organophosphorus can be very easily absorbed from the skin, the lungs and the GI tract. So either by exposure or by inhalation or ingestion. So through any route they can cause poisoning. But the quickest symptoms usually develop after inhalational route. So coming to organophosphorus poisoning, so you have to know there are two things. One is acute effect of the poisoning, which can be muscarinic, nicotinic, and on the central nervous system. And there is something called the delayed effects of OP poisoning. So let us see what is this acute effect and delayed effect. So the acute effect actually depends on the nature and type of the organophosphorus compound which the child has been exposed to. So what is the route of exposure, what is the lipid solubility of the drug and the rate of metabolic degradation. So most patients will develop symptoms within 12 hours of exposure, but some may develop even within minutes of massive ingestion, like during suicidal, if they take large quantity, they can become symptomatic within few minutes. So if they are exposed to very fat soluble organophosphates, so it will be like chronic exposure. After many days, the child may manifest with the symptoms. So again, we have three broad categories of symptoms. One is nicotinic, muscarinic and CNS. So coming to the muscarinic effect. So where all the muscarinic symptoms is in the heart. So in the heart, it can cause bradycardia, hypotension, heart block or arrhythmias. So in respiratory, they can have bronchoria, lot of bronchial secretions, bronchospasm, dyspnea, cyanosis and pulmonary edema. In GI tract, they can have cramps, severe abdominal cramps, vomiting, nausea, diarrhea and fecal incontinence. So in salivary glands, there can be excess salivation. So bronchuria, excess salivation, they can have increased sweating. Then they can, in the eyes, they can have meiosis, lacrimation, or even blurred vision. Like fecal incontinence, bladder also, they can develop urinary incontinence. And other systems, they can develop pancreatitis, garlic odor, and because of excessive sweating and loss of body fluids, child can develop even hypothermia. So these are all the muscarinic effects. So how to remember it? Looks like a large list. So maybe with this mnemonic it is easier, and I think you are very familiar also with this. So we can remember is it either as dumbbells or sludge BBB. So sludge stands for salivation, lacrimation, urination, diarrhea, gastrointestinal symptoms or emesis. And three B's are bronchoria, bronchospasm and bradycardia. The other mnemonic which you can use is dumbbells. Again D for diarrhea, urination, meiosis, bradycardia, increased bronchosecretions, emesis, lacrimation and salivation. So if you see a child with pinpoint pupils and bradycardia, so immediately you should think of a OP poisoning. Okay. So either with, so just to remember, terms ending with ATIONS or EAS. So again, one more way of trying to remember the symptoms. So coming to the nicotinic effects, so these are more of the voluntary muscles. So they can have skeletal muscle fasciculations, muscle fatigue, paralysis, respiratory muscle weakness, diminished respiratory effort. On the sympathetic ganglia, sometimes they can cause tachycardia, hypertension, mydriasis, pallor, and hyperglycemia. So, nicotinic symptoms you can remember by the days of the week: Monday, Tuesday, Wednesday, Thursday, Friday. So, mydriasis, tachypnea, W weakness, again T for tachycardia and fasciculations. So CNS effects are they can have a lot of anxiety, restlessness, delirium, psychosis, headache, dizziness, confusion, hypotonia, ataxia, seizures, insomnia, dysarthria, tremors, central respiratory depression, cardiovascular depression, and even child may go to coma also. So these are all the acute effects of poisoning. But there is something called delayed effects of OP poisoning. One of it is called as a intermediate syndrome of OP poisoning. The other is OPIDP, that is organophosphate induced polyneuropathy. Okay, organophosphorus induced delayed polyneuropathy. So these two are the delayed effects of OP poisoning. So this intermediate syndrome occurs after the resolution of the acute symptom. So like almost 24 to 96 hours after an exposure, when you usually expect a resolution of the symptom, there will be a period of full recovery, but again child suddenly develops acute respiratory and muscle paralysis, especially the proximal limb weakness involving all this organ of. So whatever the child consumed, some would be acting at the neural level, the rest would have gone and accumulated in all the fat tissues. So after some period, the all the OP which was in the fat tissue again enters the blood and will cause the delayed effects of OP poisoning. So it's always better to observe the child with OP poisoning even after a complete recovery. So the other delayed effect is the organophosphate induced delayed polyneuropathy. It occurs actually 2 to 3 weeks after exposure of large dose of OP poisoning. Like child continues to have muscle weakness and it is mostly there will be sparing of the neck muscles and proximal muscles. So only the distal muscles are affected. Then you say it is a OPIDP, that is organophosphate induced delayed polyneuropathy. So again, management, as I already told you, ABCDE. So I think you are now clear with that ABCDE. So next will be the detoxification. So you have to do the skin decontamination. So remove all the clothes, give a proper wash. GI decontamination, here you can do the gastric lavage. So it is not a contraindication. So you have to do a gastric lavage in all children with suspected OP poisoning. Coming to the specific therapy, atropine is the antidote. Okay, so main what we are worried is all the acetylcholine is coming and because of the symptoms. So we need to block that. So we will use atropine here. But what we should remember is it has no effects against the nicotinic symptoms. So it will only help in the muscarinic symptoms. So what is the dose that we use for atropine? In children more than 12 years, we can use 1 to 2 mg, and in less than 12 years, it is 0.05 mg per kg. So we have to start at least a minimum dose of 0.1 mg, and we will keep repeating the dose every 10 to 15 minutes until atropinization is achieved. So what do we mean by atropinization is not only the pupillary, because child would have come with meiosis. Once you give atropine, the pupil will become dilated. But not only that pupillary dilatation, all the bronchoria, so all that should subside. So main aim will be the reversal of the muscarinic effects. So once we achieve a full atropinization, you have to maintain that atropinization. So dose should be given every 30 to 60 minutes because the atropine has a very short half-life. Sometimes we run it like a infusion. Okay. So as your atropine will only block the action of acetylcholine, but it will not help to regenerate the cholinesterase enzyme. So that part will be done by what we call as PAM or pralidoxime. So better, and it should be given as early as possible within to 24 to 48 hours of OP binding to the acetylcholinesterase. If you give pralidoxime, it will again dephosphorylate or reactivate the acetylcholinesterase enzymes. It's always better to use it early because once we do it early, it will relieve the nicotinic symptoms also. Whereas your atropine will only help in reversing the muscarinic symptoms. So it should be started as early as possible. So the dose is 1 to 2 gram if the child is older than 12 years. If the child is less than 12 years, we give 50 mg per kg. So again, prevention is always better. So best way is to keep all pesticides out of reach of children, store them safely in a locked area, and better to keep them in their original containers. Rather, if you place it in some else, child may think it is a water or some beverage and he might just drink it. So always keep it in the original containers with clear labels because even when there is a poisoning, many of them will get some container where we can't even make out the label to know what actually child has taken. And so never reuse the containers, the pesticide containers. And if you have any left out pesticide which you have got for some for your house purpose, so dispose it properly. Never let the unused pesticides lie around. Okay. And do not eat or drink when pesticides are being sprayed around. And always have good ventilation when you are using pesticides. So these are all the prevention aspects. So the other end of the spectrum is the datura poisoning. So I think you would have all seen this plant with this thorny fruit. So this is the datura. So the whole plant, even the leaf, contains the anticholinergic alkaloids, that is the belladonna alkaloids. They include scopolamine, hyoscyamin, and traces of atropine. And the seeds contain the highest amount of atropine, that is 0.1 mg per seed. So by now you would have realized it is just the opposite of what you see in a OP poisoning because here it is the atropine which is the poison. So these will produce an anticholinergic poisoning syndrome. There what we saw was cholinergic toxicity. Here it will be anticholinergic poisoning. So this is how we remember mad as a hatter, hot as a hair, dry as a bone, and red as a beet. Okay, so same whatever symptoms we saw in OP poisoning, it will be just opposite that the child will present. So what is the lethal dose? 4 mg is the lethal dose, but even we have seen children who have become symptomatic after consuming 2 to 3 seeds also. Okay. So this is the typical anticholinergic symptoms that they develop. So once they ingest these datura seeds, symptoms will usually develop within half an hour. Okay. There, like we said, nicotinic and muscarinic. Here it is peripheral and central anti-muscarinic. It is an anticholinergic syndrome. And here they'll have only muscarinic symptoms. So what are all the peripheral anti-muscarinic effects? So first affected are the salivation and sweating and bronchial secretion. As in OP poisoning, we saw they had bronchoria or excessive secretion, excessive salivation. But here it will be the opposite. So the mouth will be dry, child will not sweat. There will be drying up of the bronchial secretion. Okay, and they will have pupillary function abnormality, ocular accommodations will be affected, So they will have symmetrical pupillary dilatation here. Because of all the dryness, they will have excessive thirst, blurring of vision, and because child is not able to lose heat because he is not sweating, so they will have hyperthermia. Temperature can go much above 40, 41, and tachycardia is a universal finding in Datura. They will have tachycardia, and sometimes they can have mild hypertension. So what are all the central antimuscarinic effects? What all we told till now was the peripheral antimuscarinic effects. So central antimuscarinic effects so usually they will have a CNS stimulation which will be followed by depression. So children usually present with agitation, confusion, disorientation. They can have ataxia, tremors and even clonic movements, and visual incoordination may occur. So these children will have lot of delirium. So they will be picking at clothes, bed sheet. They'll say they are seeing imaginary insects. Again, that's a very classical finding in a Datura poisoning. And they'll keep on muttering indistinct words. Again, it is a feature of Datura poisoning. And when very characteristic, what we say is Lilliputian hallucinations. That is, they'll see tiny animals or people.
बनाना है मैं अभी तुम्हें चाहिए क्या बनाना ये बनाना पूरा फ्राई बनाना है ये बनाना है पूरा चावल बनाना है तो बना के मुझे खाना है तो इधर
Coming to the treatment aspect, so again ABCDE. So any poisoning, first will be your ABCDE, and then mainly you have to monitor the temperature and the fluid status, because we were telling child is unable to sweat, so he will have high temperature. So monitoring of the temperature and fluids we have to be very careful. Then decontamination, if the child comes within 48 hours of consuming, it's always better to do a gastric lavage, because as we were telling, because of the atropine they will have delayed gastric emptying and the intestinal motility would also have been decreased. So even if they have consumed 48 hours earlier, still you can do a gastric lavage in these children. And specific antidote is physostigmine. And not all children with datura poisoning need an antidote. So only when they have severe hallucinations and hemodynamic instability, so only then we will use a physostigmine, and the dose is 0.02 mg per kg. So moving on, next we'll deal few points about the paracetamol toxicity or acetaminophen. So that is the drug name. So it is a NSAID, that is non-steroidal anti-inflammatory. So it is used more as an antipyretic and even analgesic also. So what is the cause for the toxicity? So what is main is there is a formation of a highly reactive intermediate metabolite, that is NAPQI, that is N-acetyl para benzoquinonimine. So this is the one which is the culprit in the paracetamol toxicity. So normally paracetamol or acetaminophen, these are the three different mechanisms of metabolism. One is there is glucuronidation and it is excreted in the urine, sulfation and in the urine. So if you see the percentage, major percentage it is the, that is what is the, whereas a very small part, 5 to 8% undergoes the cytochrome P450 degradation into this NAPQI. So this is the toxic metabolite. So in the normal therapeutic doses when you give, very small amount of this NAPQI is generated, which is immediately again conjugated with glutathione and it gets eliminated as mercapturic acid conjugate. But what happens when there is a overdose? So once there is a overdose, the glutathione stores are not able to cope up with the excess NAPQI which is being generated. So these NAPQI are hepatotoxic, so they cause the hepatocellular damage. So when is it toxic? If the ingestion is more than 140 mg per kg, then we say it is acute paracetamol toxicity. So the clinical features will progress on mainly these four phases. Phase 1 lasts for half an hour to 1 day. Initially they will have severe nausea, vomiting, pain abdomen. Then there will be a period of latency, that is from 24 to 72 hours. Symptoms subside, but if you do a lab investigation on this child, you will notice that the liver function tests are getting deranged. And then the child enters into the phase 3. Between 72 to 96 hours, child will present with just hepatic failure like symptoms. And if the child is not appropriately treated at this point, even death can ensure. But if the child is treated appropriately, then he will enter into the phase 4, which will go from 4 days to 2 weeks, where there will be complete recovery. There will be no residual damage. So how do we diagnose that it is paracetamol toxicity? So you have to do the plasma level of the paracetamol. So if you do a serum concentration, if it is more than 200 at 4 hours, more than 100 at 8 hours and more than 50 at 12 hours of ingestion, then it is suggestive that it could be toxic. This is one graph that we use. This is called as Rumack-Matthew nomogram. So once we do the serum estimation of paracetamol, so the y-axis will have the serum paracetamol levels and the x-axis will have the number of hours of duration. And imagine if we get 50 at 8 hours, so it will come somewhere here. So that shows that it is a low risk for hepatotoxicity. But if it comes higher, then it means the child is at risk of hepatocellular injury. And we should know that it is used only for single acute paracetamol toxicity, not for a chronic toxicity. So these are the parameters which we need to monitor when we are dealing with a child with paracetamol poisoning. You have to do a complete LFT, amylase, lipase, your renal function test, and CBC also, because they can have thrombocytopenia, and your PT, APTT clotting parameters may get deranged because of the hepatic injury again. So treatment, again the ABC, then the GI decontamination, that is you have to do a gastric lavage, and specific therapy is N-acetyl cysteine. So this is the specific antidote which will prevent the hepatic injury. So what is the dose that you can use? You can use both oral as well as IV. If you are using oral, it has to be 140 mg per kg loading dose, followed by 70 mg per kg, that is half the dose every 4 hours for next 17 doses. So this is the oral therapy and it has to be given within 8 hours of ingestion. So you can use even a IV preparation. IV dosage is slightly different. You have to give 150 mg per kg over 1 hour. That will be your loading dose, followed by 50 mg per kg every 4 hours. Okay, so this is the IV therapy. So certain factors which will help you prognosticate whether this child is at risk of developing severe hepatic injury. Okay, if the pH is below 7.3, if the serum creatinine is high at admission, if you have a PT which is deranged, and your clotting factors are reduced, then all these are poor prognostic factors. A brief word about iron poisoning in children. So again, one of the common cause, because the therapeutic dose that we use for children is only 3 to 5 mg per kg, and 4 times that is the toxic dose. Your 10 to 20 mg is the toxic dose. So whatever the pediatric preparations, it will have only 25 mg per 1 ml, whereas all the prenatal iron will have 65 mg. So almost it is 4 to 5 times the therapeutic level. So if the child finds, and all these iron tablets are very colorful, so child is attracted and tends to eat these tablets. So again, just like in paracetamol toxicity, again in iron poisoning you have 5 stages. Stage 1 is stage of nausea, vomiting. Stage 2 is a latent phase. Again, stage 3 child will suddenly go to a shock-like stage and they'll have multi-organ dysfunction. So in stage 4 they can have hepatic failure, and stage 5 child may develop a gastric outlet obstruction. So toxic dose ranges, if they have less than 20 mg per kg body weight, then they'll have mild symptoms. 20 to 60 mg per kg body weight is potentially serious, and more than 60 mg per kg body weight is lethal. So clinical symptoms I have almost covered. So lab test, we have to do a free serum iron. If the free serum iron is less than 50, then toxicity is unlikely. If it is 50 or more, then toxicity manifests. And total serum iron more than 350, definitely toxicity is there. Treatment same ABCD, GA decontamination, and definitive therapy is chelation with desferoxamine. So what is the dose that we use? 15 mg per kg per hour as IV infusion. And if in very severe cases, you can consider even hemodialysis also. So just coming to the last part, that is the corrosive poisoning. So corrosives, by that we mean the strong acids or alkalis. So acid agents are usually used in your toilet cleaners and even in the automobile battery fluids. And they mainly contain the hydrochloric acid as the sulfuric acid. And alkaline agents are all our laundry detergents and soaps. So mainly acid and alkali, they affect. Alkali involves mainly the esophagus and acid usually involves the stomach. So what happens when the child takes alkali? Strong alkali will act on the esophageal mucosa. So it will cause a liquefactive necrosis there and can cause full thickness burns of the esophagus and cause perforation. So what happens if it is acid? So acid, it reaches the esophagus, there will be some amount of coagulative necrosis and it gets transported to the stomach along the antrum. They form coagulum and ultimately they will cause the pyloric stricture. So acid stomach and alkali esophagus. So as soon as the child consumes, so he will develop burns of the lips and tongue. So because of the severe pain, they can have excessive drooling and refusal to drink. They can even have dysphagia, aspiration pneumonia, hematemesis, and even perforation of the esophagus and stomach in severe cases. And as a terminal event, they can develop acute renal failure, convulsions, and coma. So complications is divided as early complications and late complications. Early is within 72 hours, late is after. So early is esophageal perforation, stomach perforation, severe glottic edema causing respiratory obstruction or circulatory collapse. Late complications are esophageal stricture, pyloric stenosis. Okay. So treatment is, first aid is you have to immediately dilute whatever the child has taken. So you can dilute it with around 500 ml of water or milk. So never try to use, if the child has taken, automatically you will think why not give some alkali so that it will neutralize. No. If you use an alkaline substance like bicarbonates, they will release carbon dioxide. So it will increase the respiratory distress and may cause perforation again. For alkali, again you can neutralize with 500 ml of water. So specific treatment is keep a NGT, keep the child NPO, and no lavage should be performed. If there is signs of peritonitis, you will have to do an emergency laparotomy. Again, for alkali injection, you have to do a esophagoendoscopy to look for the degree of esophageal burns. If there is perforation, again you will have to do surgery. And if there are burns without perforation, then you can use some amount of steroids at the dose of 2 mg per kg. So just a flow chart to depict. If it is corrosive, take attention to ABC, take X-rays to know whether there is any perforation evidence. Start IV fluids, keep the child nil by mouth, and ranitidine can be used. Then you will have to do a duodenoscopy or a barium swallow at 24 to 48 hours. If there is no injury, child is able to feed well, you can discharge. If there is injury or signs of perforation, then you will have to take a surgical opinion. So I have tried to cover most of the common poisonings in this class. Thank you.
ಮೀಟಿಂಗ್ ಕ್ಲೋಸ್ ಮಾಡ್ಬೋದಾಯ್ತು.
ಮಾಡಿ